Dear students, in this video I'm going to talk about cardiac arrhythmias, mechanism of cardiac arrhythmias, types of cardiac arrhythmias, classification of antiarrhythmias drugs and pharmacology of those drugs. So let's get right into. Cardiac arrhythmia results from alterations in the orderly sequence of depolarization followed by repolarization in the heart. Nearly 3 out of 4 patients of acute myocardial infarction, MI, and about half of those given a general anesthetic exhibit at least some irregularity of cardiac rhythm. Cardiac arrhythmias may result in alterations in heart rate or rhythm and arise from alterations in simple generation or conduction. Arrhythmias are the most important cause of sudden cardiac death. Abnormal automaticity or impaired conduction or both underlie cardiac arrhythmias. Ischemia, electrolyte and pH imbalance, mechanical injury, stretching, neurogenic and drug influences, including antiarrhythmics themselves, can cause arrhythmias by altering electrophysiological properties of cardiac fibers. Impulse generation and conduction. The electrical conduction system of the heart transmits signals generated usually by the sinoatrial node to cause contraction of the heart muscle. The pacemaking signal generated in the sinoatrial node travels through the right atrium to the atrioventricular node, along the bundle of his and through bundle branches to cause contraction of the heart muscle. This signal stimulates contraction first of the right and left atrium, and then the right and left ventricles. This process allows blood to be pumped throughout the body. The conduction system consists of specialized heart muscle cells, and is situated within the myocardium. There is a skeleton of fibrous tissue that surrounds the conduction system which can be seen on an ECG. Dysfunction of the conduction system can cause irregular, fast, or slow heart rhythms. This picture shows the electrical conduction system of the heart. Cardiac action potential. The cardiac action potential is a brief change in voltage, membrane potential, across the cell membrane of heart cells. This is caused by the movement of charged atoms, called ions, between the inside and outside of the cell, through proteins called ion channels. The cardiac action potential differs from action potentials found in other types of electrically excitable cells, such as nerves. Action potentials also vary within the heart. This is due to the presence of different ion channels in different cells. Divided into 5 phases, 0, 1, 2, 3, 4. Phase 0, rapid depolarization. Phase 1, early repolarization. Phase 2, plateau phase. Phase 3, rapid repolarization. Phase 4, resting phase, diastolic depolarization. This slide shows the events happen during 5 phases of cardiac action potential. Phase 0 begins, sodium channels open and sodium ions rush into the cell. This sodium influx rapidly drives the negative resting internal charge to 0 state of depolarization and a brief overshot positive charge. The resulting positive voltage opens potassium channels during phase 1 and potassium efflux decreases the internal positive charge back to about +0-. Phase 2 begins, calcium channels remain open allowing calcium ion influx to occur. Calcium ions induce myofibril contraction. At the end of phase 2, calcium channels close. During phase 3, repolarization, potassium channels continue to efflux, making the internal charge more negative. The phase 4 hyperpolarized resting state is achieved by ATP-powered outward pumping of sodium, calcium ions. The negative charge is maintained by sodium-potassium ATPase that pumps 3 sodium ions out for every 2 potassium ions it brings into the cell. In contrast, ordinary cardiomyocytes, pacemaker cells do not sustain a stable phase 4 negative internal charge. Instead, when a pacemaker cell reaches the hyperpolarized voltage phase 4, sodium ions slowly leak through special slow sodium channels. Sodium raises the pacemaker cell's internal charge toward the threshold voltage. Phase 0, at threshold voltage, calcium channels open and calcium ions flood into the cytosol. Calcium ions quickly raise the internal charge, depolarizing the pacer cell. This action potential creates an electrical wave of depolarization that spreads from one pacer cell to another through gap junctions that interface with connecting pacemaker cells and cardiomyocytes. Increased internal calcium ions induce atrial myofibril contraction. Depolarization closes the calcium channels. Phase 3, repolarization begins as K+ channels open, allowing the positively charged K+ ions to exit, while the Na+ and Ca++ ion pumps work to remove those ions and return the internal charge toward the negative hyperpolarized state. This picture shows the wave segments in the ECG, where the P segment is due to contraction of atria. QRS segment is due to contraction of ventricles. T segment is due to repolarization of ventricles. Now we will move on the important mechanisms of cardiac arrhythmias. There are 4 different mechanisms. They are: the first one is enhanced/ectopic pacemaker activity. The second one is after depolarizations, which is divided into 2. They are early after depolarization and delayed after depolarization. The third one is re-entry, which is divided into 2. They are circus movement type and micro re-entry circuit. The fourth one is fractionation of impulse. Let's see one by one. Enhanced/ectopic pacemaker activity. An ectopic pacemaker is an excitable group of cells that causes a premature heartbeat outside the normally functioning SA node of the heart. In a normal heartbeat rhythm, the SA node usually suppresses the ectopic pacemaker activity due to the higher impulse rate of the SA node. However, in the instance of either a malfunctioning SA node or an ectopic focus bearing an intrinsic rate superior to SA node rate, ectopic pacemaker activity may take over the natural heart rhythm. In these patients, the slope of phase 4 depolarization may be increased pathologically in the automatic fibers, or such activity may appear in ordinary fibers. Ectopic impulse may result from current of injury. Myocardial cells damaged by ischemia become partially depolarized. A current may flow between these and normally polarized fibers, injury current, and initiate an impulse. After depolarizations, these are secondary depolarizations accompanying a normal or premature action potential, AP. After depolarization is 2 category. They are: early after depolarization, delayed after depolarization. Early after depolarizations occur with abnormal depolarization during phase 2 or phase 3, and are caused by an increase in the frequency of abortive action potentials before normal repolarization is completed. Phase may second be interrupted due to augmented opening of calcium channels, while phase 3 interruptions are due to the opening of sodium channels. Early after depolarizations can result in torsades de pointes, tachycardia, and other arrhythmias. Early after depolarizations can be potentiated by hypokalemia and drugs that prolong the QT interval, including class IA and 3 antiarrhythmic agents. Delayed after depolarization, DAD. Delayed after depolarizations begin during phase 4. After attaining resting membrane potential, RMP, a secondary deflection occurs which may reach threshold potential and initiate a single premature action potential. Generally result from calcium overload, example digitalis toxicity, ischemia reperfusion. The overload of the sarcoplasmic reticulum may cause spontaneous calcium release after repolarization, causing the released calcium to exit the cell through the 3-sodium calcium exchanger. This results in a net depolarizing current. Because an action potential is needed to trigger after depolarizations, arrhythmias based on these have been called triggered arrhythmias. After depolarization action potential are shown in the slide with the examples of arrhythmias. Re-entry due primarily to abnormality of conduction, an impulse may recirculate in the heart and cause repetitive activation without the need for any new impulse to be generated. These are called reentrant arrhythmias. Circus movement type: it occurs in an anatomically defined circuit. A premature impulse, temporarily blocked in one direction by refractory tissue, makes a one-way transit around an obstacle, natural orifices in heart, infarcted or refractory myocardium, finds the original spot in an advanced state of recovery and re-excites it, setting up recurrent activation of adjacent myocardium. Micro-reentrant circuit it may form at the junction of a Purkinje fiber with ordinary ventricular fiber, gate region. One of the branches of the Purkinje fiber may get sufficiently depolarized to cause unidirectional block, which is shown in the figure. Extremely slow conduction at this site due to slow channel depolarization and markedly abbreviated action potential duration and effective refractory period. Makes reentry possible in a short loop of tissue. Fractionation of impulse. When atrial effective refractory period is brief and inhomogeneous, under vagal overactivity, an impulse generated early in diastole gets conducted irregularly over the atrium, i.e. it moves rapidly through fibers with short effective refractory period, which have completely recovered, slowly through fibers with longer effective refractory period, partially recovered, and not at all through those still refractory. Thus, asynchronous activation of atrial fibers occurs. Atrial fibrillation, AF. This arrhythmia must be initiated by a premature depolarization, but is self-sustaining, because passage of an irregular impulse leaves a more irregular refractory trace and perpetuates the inhomogeneity of ERPs. The important cardiac arrhythmias are 1. Extrasystoles, ES, are premature beats due to abnormal automaticity or after depolarization arising from an ectopic focus in the atrium, AES, AV node, nodal ES, or ventricle, VES. The QRS complex in VES is broader and abnormal in shape. 2. Paroxysmal supraventricular tachycardia, PSVT, is sudden onset episodes of atrial tachycardia where the heart rate will be between 150 to 200 per minute with 1:1 atrioventricular conduction, mostly due to circus movement type of re-entry occurring within or around the AV node or using an accessory pathway between atria and ventricle. Wolff-Parkinson-White syndrome. 3. Atrial flutter, AFI, atria beat at a rate of 200-350 per min and there is a physiological 2:1 to 4:1 or higher AV block, because AV node cannot transmit impulses faster than 200 per min. This is mostly due to a stable re-entrant circuit in the right atrium, but some cases may be due to rapid discharge of an atrial focus. 4. Atrial fibrillation, AF, atrial fibers are activated asynchronously at a rate of 350 to 550 per minute, due to electrophysiological inhomogeneity of atrial fibers, associated with grossly irregular and often fast, 100 to 160 per minute, ventricular response. Atria remain dilated and quiver like a bag of worms. 5. Ventricular tachycardia is a run of 4 or more consecutive ventricular extrasystoles. It may be a sustained or non-sustained arrhythmia, and is due either to discharges from an ectopic focus, after depolarizations or single-site, monomorphic, or multiple-site, polymorphic, reentry circuits. 6. Torsades de points, French, twisting of points, is a life-threatening form of polymorphic ventricular tachycardia with rapid asynchronous complexes and an undulating baseline on ECG. It is generally associated with long QT interval. 7. Ventricular fibrillation, VF, is grossly irregular, rapid, and fractionated activation of ventricles resulting in incoordinated contraction of its fibers with loss of pumping function. It is fatal unless reverted within 2 to 5 minutes, is the most common cause of sudden cardiac death. 8. Atrioventricular, AV, block is due to depression of impulse conduction through the AV node and bundle of His, mostly due to vagal influence or ischemia. First degree AV block, slowed conduction resulting in prolonged PR interval. Second degree AV block, some supraventricular complexes are not conducted, drop beats. Third degree AV block, no supraventricular complexes are conducted, ventricle generates its own impulse, complete heart block. Arrhythmogenic potential of antiarrhythmics. Most antiarrhythmics can themselves precipitate serious arrhythmias, especially during long-term prophylactic use. This slide shows the drugs that prolong QT interval, have potential to precipitate torsades de points. Classification: antiarrhythmic drugs. Antiarrhythmic drugs act by blocking myocardial sodium, potassium, or calcium channels. Some have additional or even primary autonomic effects. Classification of antiarrhythmic drugs has been unsatisfactory, because many drugs have more than one action. Vaughan Williams and Singh, 1969, proposed a four-class system which takes into account the most important property of a drug which is apparently responsible for its antiarrhythmic action in the clinical setting. This system, though arbitrary, is widely accepted. This slide shows the classification of antiarrhythmic drugs with the examples. Some Class 1A agents also have Class 3 property. Propranolol has Class 1 action as well. Sotalol and beryllium have both Class 2 and Class 3 actions. Pharmacological goal. The ultimate goal of antiarrhythmic drug therapy are to restore normal sinus rhythm and conduction, and the next one is to prevent more serious and possibly lethal arrhythmias from occurring. Antiarrhythmic drugs are used to decrease conduction velocity, change the duration of the effective refractory period, and finally to suppress abnormal automaticity. Let's see different classes of antiarrhythmic drugs one by one. Class 1. The primary action of drugs in this class is to limit the conductance of sodium and potassium across cell membrane. This is what leads to a local anesthetic action of these drugs. They also reduce rate of phase 4 depolarization in automatic cells. Class 1 antiarrhythmic drugs are divided in subclasses. They are subclass 1A, subclass 1B, and subclass 1C. The subclass 1A containing the oldest antiarrhythmic drugs quinidine and procainamide are open-state sodium channel blockers which also moderately delay channel recovery, 1 to 10 seconds, suppress AV conduction and prolong refractoriness. The sodium channel blockade is greater at higher frequency, premature depolarization is affected more. These actions serve to extinguish ectopic pacemakers that are often responsible for triggered arrhythmias and abolish re-entry by converting unidirectional block into bidirectional block. They also slows the rate of rise in phase 0 and prolong the action potential and effective resting potential. It reduces the slope of phase 4 spontaneous depolarization. It also increases the QRS and QT interval. Quinine. It is the dextroisomer of the antimalarial alkaloid quinine found in cinchona bark. It is also used as an antimalarial, antipyretic, skeletal muscle relaxant, and it's also exhibit atropine-like action. Mechanism of action. Quinidine binds to open and inactivated sodium channels and prevents sodium influx, slowing the rapid upstroke during phase 0. It also decreases the slope of phase 4 spontaneous depolarization and inhibits potassium channels. Adverse effect. It causes fall in BP, weak alpha-adrenergic blockade and cardiac depression. Decreased skeletal muscle contractility. Uterine contractions. Vomiting, diarrhea and neurological effects like ringing in ears, vertigo, deafness, visual disturbances, and mental changes, which is called as synchronism. Contraindication. Rise in blood levels and toxicity of digoxin due to displacement from tissue binding and inhibition of glycoprotein-mediated renal and biliary clearance of digoxin. Marked fall in BP in patients receiving vasodilators. Risk of torsades de pointes is increased by hypokaliemia caused by diuretics. Synergistic cardiac depression with beta blockers, verapamil, K+ salts, treat ventricular tachyarrhythmias. Used in the termination of ventricular tachycardia. Procainamide. Procaine derivative which have quinidine-like action. Mechanism of action. Procainamide binds to open and inactivated sodium channels and prevents sodium influx, slowing the rapid upstroke during phase 0. Adverse effect, it might cause hypotension and hypersensitivity reactions. Uses. It is used in premature atrial contractions and paroxysmal atrial tachycardia. Dose, 1 to 1.5 gram, rate of 20 to 50 mg per min as IV. Drug interaction. Cimetidine inhibits the metabolism of procainamide. Disopyramide. Mechanism of action. Disopyramide produces a negative ionotropic effects that is greater than weak effect exerted by quinidine and procainamide, and unlike the latter drugs, disopyramide causes peripheral vasoconstriction. Adverse effect: myocardial depression, urinary retention, constipation. Uses: it is used in ventricular tachycardia, AF and AFI. Drug interaction: in the presence of phenytoin, the metabolism of disopyramide is increased and the accumulation of its metabolite is also increased, thereby increasing the probability of anticholinergic properties. Moricizine. Mechanism of action: moricizine reduces the maximal upstroke of phase 0 and shortens the cardiac transmembrane action potential. The phenomenon may explain the efficacy of moricizine in suppressing rapid echotopic activity. Adverse effect: nausea, dizziness, AV block. Uses: it is used to treat ventricular tachycardia. Contraindication: AV block and drug hypersensitivity. Drug interaction: no significant interactions like other drugs. Subclass 1b. These drugs block Na+ channels more in the inactivated than in the open state, but do not delay channel recovery time 1 second. They do not depress AV conduction or prolong, even shorten, APD, ERP, and QT. They shorten phase 3 repolarization, reduce the duration of the cardiac action potential, prolong phase 4. Drugs in this subclass are lidocaine, mexiletine and phenytoin. Lidocaine: it decreases the duration of action potential. Mechanism of action: it shortens phase 3 repolarization and decreases the duration of action potential. Adverse effect: drowsiness, slurred speech, confusion, and convulsions. Uses: ventricular arrhythmia, digitalis toxicity. Contraindication: lidocaine is contraindicated in the presence of second and third degree heart block, since it may increase the degree of block and can abolish the idioventricular pacemaker responsible for maintaining the cardiac rhythm. Drug interaction: propranolol increases its toxicity. The myocardial depressant effect of lidocaine is enhanced by phenytoin administration. Phenytoin. Phenytoin was originally introduced for the control of convulsive disorders but now also been shown to be effective in the treatment of cardiac arrhythmias. Uses: anesthesia, open heart surgery, digitalized induced and ventricular arrhythmia in children. Adverse effect: respiratory arrest, hypotension. Contraindication: severe bradycardia, severe heart failure, AF and AFI. Drug interaction: plasma phenytoin concentrations are increased in the presence of chloramphenicol, disulfiram, and isoniazid, since the later drugs inhibit the hepatic metabolism of phenytoin. Mexiletine. Mechanism of action: it is a local anesthetic and an active antiarrhythmic by the oral route, chemically and pharmacologically similar to lidocaine. It reduces automaticity in PF, both by decreasing phase 4 slow and by increasing threshold voltage. By reducing the rate of zero-phase depolarization in ischemic PF, it may convert one-way block to two-way block. Adverse effect: tremor, hypotension, bradycardia. Contraindication: cardiogenic shock, second or third degree heart block. Uses: VA, congenital long, QT syndrome. Drug interaction: when mexiletine is administered with phenytoin or rifampin, since these drugs stimulate the hepatic metabolism of mexiletine, reducing its plasma concentration. Subclass 1c. Flecainide, encainide, propafenone, moricizine are belongs to subclass 1c. They show markedly slow phase 0 depolarization and slow conduction in the myocardial tissue. Minor effects on the duration of action potential and ERP. They also reduce automaticity by increasing threshold potential rather than decreasing slope of phase 4 depolarization. Flecainide, encainide. Flecainide suppresses phase 0 upstroke in Purkinje and myocardial fibers. This causes marked slowing of conduction in all cardiac tissues, with a minor effect on the duration of the action potential and refractoriness. Automaticity is reduced by an increase in the threshold potential rather than a decrease in the slope of phase 4 depolarization. Its proarrhythmogenic effect on patients with coronary artery disease. Uses: it is used ventricular arrhythmia. Adverse effect: it may cause a torsades de pointe, visual disturbances and headache, digoxin toxicity / Contraindication: cardiogenic shock. Propafenone. Structural similarities with propranolol. Contraindication: heart failure. Adverse effect: it may cause proarrhythmogenic effect, metallic taste and constipation. Dose 150 to 200 mg at 8 hourly. Used in the VT and supraventricular arrhythmias. Moricizine. Has all three subclass properties: less proarrhythmogenic effect, used in ventricular arrhythmias, and doses 200 to 400 mg orally at 8 hourly. Class 2 drugs: propranolol, metoprolol, esmolol, acebutolol. These drugs depress phase 4 depolarization, depress automaticity, prolong the AV conduction, increase ERP, prolong PR interval, decrease the heart rate and contractility. Propranolol. Mechanism of action. Propranolol decreases the slope of phase 4 depolarization and other ectopic foci. Prolong the ERP of AV node. Used in the AF and digitalis-induced arrhythmias. Adverse effect: it may cause hypoglycemia into infants, asthma, and bronchospasm. Contraindication: asthma, bradycardia, severe congestive heart failure. Acebutolol. Acebutolol is a cardioselective beta-1 adrenoreceptor blocking agent that also has some minor membrane stabilizing effect on the action potential. Mechanism of action. Acebutolol reduces blood pressure in patients with essential hypotension primarily through its negative ionotropic and chronotropic effects. Adverse effect: bradycardia, GI upset. Used in the VA and angina pectoris. Contraindication: cardiogenic shock, severe bradycardia. Esomolol. Esomolol is a short-acting I.V administered beta-1 selective adrenoreceptor blocking agent. It doesn't possess membrane stabilizing activity. Adverse effect: hypotension, nausea, headache, dyspnea. Used in supraventricular tachyarrhythmias. Contraindication: asthma, sinus bradycardia, AV block, severe CHF. Class 3. K+ channel blockers. The characteristic action of this class is prolongation of repolarization. AP is widened and ERP is increased. The tissue remains refractory even after full repolarization. Reentrant arrhythmias are terminated. Amiodarone, bretylium, sotalol belongs to this category. They are potassium channel blockers, increase the action potential or affecting resting potential without affecting phase 0 or 4. It also prolong QT and PR. Amiodarone. This unusual iodine-containing highly lipophilic long-acting antiarrhythmic exerts multiple actions. Prolongs APD and QT interval attributable to block of myocardial delayed rectifier potassium channels. Preferentially blocks inactivated Na+ channels, like lidocaine, with relatively rapid rate of channel recovery, more effective in depressing conduction in cells that are partially depolarized or have longer APD. Inhibits myocardial Ca2+ channels and has non-competitive beta-adrenergic blocking property. Pharmacokinetics: amiodarone is incompletely and slowly absorbed from the GIT. On daily oral ingestion the action develops over several days, even weeks. However, on IV injection, action develops rapidly. Uses equals VF, VT and AF. Loading dose 150 mg, slow for maintenance dose -1 mg per minute for 6 hours. Adverse effect: heart block, pulmonary, hepatitis, dermatitis, corneal deposits and thyroidism. Drug interaction: digoxin, diltiazem and quinidine. Bretylium. It is an adrenergic neuron-blocking drug introduced in 1960 as antihypertensive, but was soon withdrawn. It was reintroduced for parenteral use to facilitate reversal of VF, but is not available in India or the USA, and is rarely used elsewhere. Sotalol. Non-cardioselective blocker. Has both class 2 and class 3 actions. Oral dose 80 mg twice daily. Proarrhythmic effect. C/I. Hypokaliemia. Drug interactions. Drug with inherent QT interval prolonging activity may enhance the class 3 effects of sotalol. This slide shows the newer class 3 drugs. Class 4 drugs. The primary action of this class of drugs is to inhibit calcium-mediated slow-channel inward current. Mechanism of class 4 drugs. They block L-type calcium channels. Reduce the rate of phase 4 in SA/AV node. Slow conduction, prolong ERP. ANS also reduce the phase 0 upstroke. Verapamil and diltiazem are the two important drugs in this class. Verapamil. Verapamil have stronger action on heart than smooth muscle. It is used in supraventricular arrhythmia. Dose is 80 to 120 mg 3 times a day. Adverse effect like ankle edema, constipation are seen. Contraindication of this drug is AV block, LVF, hypotension and WPW. Verapamil has poor efficacy in ventricular arrhythmias. In contrast to beta blockers, verapamil prophylaxis does not reduce mortality in post-ME patients. In some patients of VT, IV injection of verapamil has precipitated VF, therefore contraindicated. It is also not recommended for digitalis toxicity, because additive AV block may occur. It is contraindicated in partial heart block and sick sinus. Diltiazem. The direct cardiac actions of diltiazem are similar to those of verapamil. However, they are less marked. It is an alternative to verapamil for PSVT. For rapid control of ventricular rate in AF or AFL, IV diltiazem is preferred over verapamil, because it can be more easily titrated to the target heart rate, causes less hypotension, and myocardial depression can be used even in the presence of mild to moderate CHF. So this presentation we have learned about the cardiac arrhythmias, mechanism of cardiac arrhythmias, types of cardiac arrhythmias, classification of antiarrhythmias drugs and pharmacology of those drugs. Thank you.